Much. I got charged with talking to you about OCT strengths and pitfalls. Okay, so let's do a case together. This is a diagnostic angiogram of a patient with triple vessel disease or some mild disease in the circumflex and RCA, but there's an LAD culprit lesion. And so a lot of you have heard me talk about this concept of MLD max, which is a collection of what we learned from Illumian 3 and Illumian 4. What are the things that we learned on intravascular imaging that actually impact clinical outcome? The morphology, which is calcification, landing your stent into normal vessels and getting the biggest possible highway and increasing the diameter of the stent. And finally, the things that impacted the clinical outcome are medial dissection, perhaps apposition will probably change that in MLD max to area, and finally expansion. So what do you do when you're going to run an OCT? Well, you have to remember the 4 Ps, which is to position the catheter distal to the lesion, purge it so you don't have blood inside the catheter like we're doing here, and then do your pullback. And you can see this is being performed in real time, so this OCT guidance can happen very, very quickly. You probably need about 6 minutes if OCT is set up in your lab without having to roll in a cart. The user interface is excellent. Out of all of the strategies, I think that the user interface for the Abbott OCT system is superior. It gives you the information you need to know, the minimal lumen area, the length of the lesion from proximal to distal. It gives you the angiographic co-registration that has a standard deviation of less than 0.2 millimeters, and it also identifies for you calcium. This is the advantage of integrating artificial intelligence into your program, right? So you automatically identify where the calcium is. It shows you the calcium not only on the cross section, but also on the angiogram and on your multiplanar reconstruction distally. That allows you to target your therapy, which has major benefits. Of course, as we moved in Illumian, we moved to an external elastic lamina guided stent sizing strategy, and now the EL is detected automatically for you when you see 180 degrees of vessel or more. And so all of this together, allowing you the traditional measurements, gives you the features that you need to perform PCI with imaging guidance in a very rapid way. So let's take this case. We start this case at 10:49 in the morning, as you can see here. And the first thing we want to do is look at the morphology. And one of the nice things about OCT is you can see all of the layers of the artery with exquisite detail. And so that has particular value, particularly when you're trying to size your stents, but also to looking at pathology. And when we look at pathology, there's basically 2 concepts. Light is either attenuated, high attenuation, or low attenuation. High attenuation means the light is blocked, like shining a light into a bowling ball. Low attenuation is like shining a light into a crystal. The light is refracted, but it's not blocked. And so what that does is give you a very simple way to interpret images. Is the light bent or blocked? And if you look at that in an algorithmic way, you can very quickly identify all of the things that you need to make a clinical decision. If it's in the lumen, is it thrombus or a calcified nodule? If it's outside the lumen, is it lipid or calcium? And then what we can do is do a morphology-guided lesion preparation strategy. If we have fibrotic or lipid disease, we are mostly direct stenting. If we have moderate to severe calcification, we're very aggressive up front. We created for you guys the rule of 5s, which is when stents end up underexpanded with moderate to severe calcification. The rule of 5 says that if you have 0.5 millimeter of thickness of calcium in the minimal point, 5 millimeters in length, and 50% of the vessel arc, you have a significant risk of your stent being underexpanded. Hence, we look for these on the OCT guidance. And this is one of the advantages of using the OCT AI system. It automatically identifies for you the arc of calcification, the maximal thickness, it shows you on the cross section, and it will also allow you to toggle through the lesion by looking through the most calcified segment. You've heard me a lot recently talk about eccentric calcification being this sort of silent killer, and you can very easily look at the eccentricity of the calcium by shifting the knob by going from 90 to 180. In fact, if you go to 270, you can see the most severe calcium and the one that's most likely to end up underexpanded. Length here is also very quick and easy. When you look at the OCT, you can look at it as a multiplanar reconstruction. We call this the OCT 3D luminogram. For those of you familiar with CT, it's basically a flattened MIP. And what we can do in this situation is actually go into the lesion and find a more normal reference zone, and then do the same thing on the opposite side by scrolling into the lesion and then scrolling out of the lesion and finding a normal zone. Once we find these two normal zones, we measure the length. There's no commercially available 43 millimeter stent, and so what we do is we taper on the more normal side to get to a commercially available drug-eluting stent. Now, one of the beauties of the OCT is the markers that you can see. The OCT length assessment allows you to land your stent exactly within the white markers in real time in a dynamic way to minimize the risk of geographic miss. And so here you can see us basically lining up the lesion by going into the lesion and then out of the lesion. We always taper into the more normal side of the artery, and what that does is allow us to get a commercially available drug-eluting stent size. Here you can see we've picked up at 43.8. We taper into the vessel, and then we get to the point where it's very easy for us to place our stent. When we look at diameter, you've heard me talk about this from Illumian. We figured out that if you use an external elastic lamina-guided procedure, you end up with a larger stent than if you use lumen-guided. And that is really the hallmark of getting the largest minimal stent area, which drives the clinical outcome. We do this measurement both on the proximal and distal reference. The distal reference picks your stent, and the proximal reference picks your proximal optimization balloon. And here you can see us doing this all in an automated measure because the Ultron 2.0 automatically identifies the lumen and automatically identifies the external elastic lamina. And you can see how accurate this is by making our own measurement against the artificial intelligence. So when doing this, we can very quickly determine our stent size and very quickly determine our proximal optimization technique. One of the nicest features about this is we can make PCI much more like a TAVR, where we're not having to think on the fly of the things that we need. In fact, we pick all of our equipment up front, and like in our hospital, we have a central supply room. I get everything I need from the procedure from the beginning. And this feature, which came out in Ultron 2.0, which is the dynamic guidance, shows you exactly in real time on a moving angiogram where to place your stent based on your markers. And this is an advantage of basically eliminating geographic miss. So you can see that we start at 10:49. This procedure is taking us about 20 minutes or so. It's now 11:19, and we're doing our post-PCI OCT guidance. And what I love about OCT, particularly Ultron, is look how fast it is to assess the post-PCI procedure. You have an automated assessment of the stent. As a result, we can identify the stent quickly, we can identify the expansion quickly and the minimal stent area, we can identify exactly where we need to act based on both the angiogram and on the OCT. And finally, what you'll see here is a malapposition indicator, which tells us that there's no malapposition. And finally, if we need to post-dilate, again, we're able to identify the external elastic lamina as well as the lumen. All of this is automated for us. So how do we do this in real time? We can very quickly move from the user interface and move into this medial dissection. When we have a dissection that goes into the wall, into the median, that's more than a quadrant, we want to treat it. You can see that here. We very quickly can look at the edge of the stent and see that there's actually no medial dissection. Here distally, and then we're going to jump over to the proximal and show the same thing. And so what this allows us to do is, again, move very quickly through the procedure without having to have many further steps. You can see some proximal malapposition, which is automatically identified by the OCT system. Apposition, as you can see, as I mentioned before, it will automatically detect it based on the threshold that you want. Here we put the apposition indicator at 0.1 millimeters. You could put it at 0.3 millimeters. Here's how you change the threshold for the apposition or the expansion so that you can do it based on the updated guidelines. So this is dynamic as we learn more about this area. And finally, of course, what we want to know is how expanded the stent is and what's the minimal stent area, because that drives the outcome. All of that information is automatically available for you. In fact, the OCT creates an interpolated reference vessel diameter of how big the stent should be on each and every frame. Now here you can see the region of interest is automatically identified and the expansion is showing an underexpansion. And what that allows us to do is therefore target our post-dilation just to that area. And by doing that, what we can do is optimize our PCI very, very quickly without the risk of edge dissection. And now you can see that just simply by doing this one post-dilation, we've increased the expansion from 69 to 84% and the procedure's complete. But of course, everything that glitters is not gold, and OCT has significant pitfalls. Oh, sorry, can I have my last slide up?
Can we have the slides back, please?
Just the last slide. I just want to go through the pitfalls very quickly. The two biggest pitfalls are obviously poor flush clearance. Still, you can see in 20% of cases in big vessels, we get poor flush. And the second is this concept of non-uniform rotational distortion that happens when the catheter bends. Finally, you'll see this in our urointervention patient paper. Blood in the catheter can be problematic. Inadequate flush can sometimes mimic thrombus. And finally, we have to remember this concept of the pseudoerosion, which many of you might not recognize, but when you have a little bit of blood inside the artery, you can sometimes think there's an erosion that's not present because of the scatter of light off of the blood. So this is how I like IVUS versus OCT. OCT gets most of the marks for PCI guidance, but IVUS still has a very significant role in lesion subsets or niches like CTO, left main, advanced CKD like we just saw, and multivessel disease. Thank you very much.